Morning, everybody. So today I will be presenting on urinary tract infections in children. Uh, so, basically this presentation would be looking into introduction, microbiology, diagnosis, treatment, evaluation of UTI, and a brief talk about vesico-ureteric reflux, which is one of the very important causes of UTI. So, how do you define UTI? It's basically infection of the urinary tract. So you need to identify a growth of a significant number of organisms of a single species in urine, which is very important because you can have contaminated growth, which is not a true UTI. So to define a person or a child to have a UTI, you need to have a significant growth of greater than 10 to the power of 5 of a significant organism, and that has to be also a single species. And during the time when you are defining a child to have a UTI, the patient should be symptomatic. So it's a very common infection both in infants and children. It's slightly higher in girls, 3 to 10% in girls will have a UTI episode before 14 years of age, whereas in boys it's slightly less at 1 to 3%. Uh, in young infants and children, because their symptoms are less, you often miss the diagnosis. And again, to emphasize, to make a diagnosis of UTI, you need to have a positive urine culture. So the most common microbiology that you would get it from a urine culture is E. coli, which with a percentage of 80%, and other gram-negative bacteria that grow are Klebsiella, Proteus, Enterobacter, and Citrobacter. Uh, Proteus can be associated with caliculi. So any child who has a urinary tract infection with Proteus, you need to make sure that the child gets an ultrasound to so that any renal caliculi can be investigated further. The other bacteria that are common to cause UTI are Staphylococcus, Saprophyticus, Enterococcus, and Staphylococcus aureus. Viruses and fungi are very unlikely to cause UTI. And the risk factors for fungal UTI is usually in children who are immunosuppressed or who are on long-term use of broad-spectrum antibiotic therapy or who have an indwelling urinary catheter. They are at risk of having a fungal UTI. There are various host factors that can cause UTI. So for boys, the UTI would be more common when before 1 year of age, whereas for girls, it can occur up to 4 years of age. Um, Uncircumscribed male infants with fever have 4 to 8 fold higher prevalence of UTI than a circumscribed male, because when you have a tight skin of phimosis around the foreskin, that can itself can host bacteria around it. So children who don't have circumcision are at a higher risk to develop UTI. Again, female infants, because of the way the anatomy is there, they have 2 to 4 fold higher prevalence of UTI. Uh, White children are more prone compared to black children to have UTI. There is some genetic propensity with children's first degree relatives, especially with family history of vesico-ureteric reflux. They are at risk of developing UTI. And urinary obstruction, bladder and bowel dysfunction, VUR, and bladder catheterization are other host factors. So for young children, it is very difficult to have classical symptoms. Um, so less than 2 years, any child who is presenting with fever, vomiting, lethargy, with no clear gastro symptoms, you need to rule out UTI. So they need to get a urine sample. In young infants and young children, a recurrent fever, diarrhea, vomiting, abdominal pain, and food weight gain might be the symptoms. For older children, the children who can verbally speak, there might be symptoms of bladder irritation, like they can have dysuria, urgency, frequency, or they can have symptoms of upper UTI like abdominal pain or flank pain associated with fever. Usually adolescents may have symptoms more so of lower UTI, like having dysuria, urgency, and they might not have fever present. Some of the definitions that are that you need to know is significant bacteria is colony count of greater than 10 to the power of 5 per ml of a single species in a midstream clean catch sample. Midstream clean catch is uh, the child passes some urine and then you catch in the middle of voiding the sample purely because you are try to avoid the contamination. Definition for asymptomatic bacteria is significant bacteria in absence of symptoms of UTI. Simple UTI is a child who is diagnosed as UTI with symptoms of low-grade fever, dysuria, frequency, urgency, and they don't have symptoms of complicated UTI. Complicated UTI where they have fever of more than 100, 102, they have systemically they are toxic, they have persistent vomiting, dehydration, renal angle tenderness. So these are more of complicated UTI and their kidney function might be affected with raised creatinine. Recurrent UTI is classified as any child who has second episode of UTI. So on physical examination, what you need to see is on general examination, you need to check the vitals. BP and temperature are very important, especially like in children with recurrent UTI. You need to check their blood pressure. Growth parameters, again very important to plot them on an appropriate growth chart for height and weight because you want to make sure that the child is not failure to thrive due to chronic UTI. Abdominal examination for a mass, looking for an enlarged bladder or an enlarged kidney, secondary to an obstruction, or if children are constipated, you can feel palpable stool. So you need to do a thorough abdominal examination. And for boys and for girls who are having UTI, you might need to do an external genitalia examination to rule out any phimosis or labial adhesions. Any child who presents with UTI with urinary incontinence, you need to examine the lower back to make sure that you haven't missed any occult myelomeningocele. And you need to also evaluate for other sources of fever just before you brand them as UTI. And diagnosis, definitely you need to collect a urine sample prior to the antibiotics. So pyuria is defined as more than 10 leukocytes per millimeter cube in an uncentrifuge or more than 5 leukocytes in a centrifuge sample. You might see high white cell count in conditions such as fever, glomerulonephritis, renal stones, or presence of foreign body in urinary tract. And you can't classify a child to have a UTI by just presence of leukocytes. You need to have a bacteria in culture. So any child who has just leukocytes in the urine without any significant bacteria, then it is not a UTI. What is the best way of collecting a urine specimen for culture? Catheterization or suprapubic aspiration is preferred method of collection for non-toilet trained. For a toilet trained, you can catch the midstream clean catch urine sample. Clean catch means that you need to clean the genitalia before you are obtaining a urine sample. Again, if they have went to a toilet and they haven't cleaned it properly, you might get a contaminant sample. So children should be genitalia should be cleaned, and then you obtain a clean catch urine sample. So you see in lots of clinical practices like urine collected in a sterile bag, it definitely doesn't rule out UTA, but if a urine sample collected from a urine bag is negative, then it is unlikely to be a UTI. So if it is negative, you can take it, whereas if it is positive, then you need to take a more cleaner way of collecting a urine sample, either by clean catch urine sample in older kids or by catheterization or suprapubic aspiration. And the urine sample should not be kept outside for a long time. Like the sooner you get the urine sample, it should be sent to the lab, as you need to plate the sample within 1 hour of collection. Diagnosis: a urine culture should be repeated in case of contamination. Say if you've got a mixed growth of 2 or more pathogens, and or normally you got a flora like lactobacilli for girls or enterococci in infants and toddlers, then you need to repeat the urine sample. You should also repeat a urine culture when you strongly think that this child has a UTI, but the colony counts are not that significant, and any child whose urine is positive for nitrates on dipstick will have to have a culture to make sure that they're not having a UTI. I have put 3 algorithms like what we need to do, like from up to date, like female infants aged 3 to 24 months who are diagnosed as UTI, and the other one is febrile female infant 3 to 24 months, and a verbal child with urinary or abdominal symptoms. Just go through the presentation that has been forwarded to you. So how do you diagnose them as a UTI? So if you have taken a suprapubic aspiration, any number of pathogens is considered as significant. So there is this probability of them having an infection is 99%. If it's a catheterized sample, there should be more than 5 into 10 to the power of 4 colony per ml. That gives a probability of 95%, whereas if you catch a midstream clean catch, the colony count should be more than 10 to the power of 5, and it gives a probability of 90 to 95%. So initial evaluation, as I've said before, you need to look at the distended bladder to make sure that there is no obstructed pathology. You need to look at the palpable enlarged kidneys, significant hydronephrosis you can palpate, or polycystic kidneys you can palpate per abdomen. Tight phimosis, any vulval seneca, you need to look at it. Constipated child, you need to look for fecal mass palpability. Again, a neurological examination in lower limbs and patulous anus if you are suspecting there is fecal incontinence or urinary incontinence, and any previous surgery of urinary tract, anorectal malformation, or meningomyelocele. So what are the features of gallbladder dysfunction? These children will have recurrent UTIs. They will have persistent high-grade VUR, which is the reflux. They will have constipated impacted stools. They tend to hold and try to avoid going to the toilet. So they will be doing like squatting and holding movements, but they would be hesitant to go to the toilet. So the voiding frequency would be also less than 3 times, or they might be passing smaller tiny amounts, so they might be having more than 8 times a day. They might be straining to pass urine, or they might have poor urinary stream, and on ultrasound you might have a thickened bladder wall of more than 2 mm, and when you do an ultrasound they will be having a residual volume after they passed urine of more than 20 ml. So basically what they are doing is that they are not emptying the bladder properly, and that is again putting them to have higher risk of UTI. So which are the children? Now all children we don't obviously admit in the hospital for treatment. So the children that need to be hospitalized is children less than 2 months, or they are having features of sepsis, like they are toxic in appearance, BP is unstable, or they have poor capillary refill. Any child who is immunocompromised with UTI, they need to be admitted to the hospital. And some children will be vomiting and they are not able to tolerate their oral medication. They need to be admitted as well. And children who haven't responded to outpatient therapy, or you're not sure that they will follow up outpatients properly, they need to be admitted as well. Other children who have a simple UTI, they can be managed as an outpatient basis. So treatment for children less than 3 months of age and those with complicated UTI, they should be hospitalized and treated with IV antibiotics. So IV should be given for 2 to 3 days pending cultures, and once you get the cultures and have appropriate sensitivities based on the bacterial sensitivity, you can change to oral antibiotics provided the child condition improves. So if the child condition does not improve within 2 to 3 days, then you need to repeat the culture again and reconsider to see that whether you are missing something. So children who have a simple UTI and those above 3 months, they can be treated with oral antibiotics as an outpatient basis. So if a child is not responding to the treatment that you have given, so you need to see like if there is any resistant pathogens or the pathogen that you are treating is not susceptible to the antibiotic that you are giving, or sometimes families are not giving the antibiotics as per schedule. So they need to be re-evaluated again. So antibiotics, IV antibiotics, ceftriaxone is a preferred one. The dose is 75 to 100 milligram in 1 to 2 divided doses IV. The second one is cefotaxime, but I personally prefer ceftriaxone as the first dose. Amikacin, generally what we do is that like if a child responds to ceftriaxone and the bacteria is sensitive to ceftriaxone, we go with ceftriaxone. However, if child is not responding at 48 hours, you do need to consider to add amikacin, as it provides a more broader gram-negative coverage. Instead of amikacin, like in some other countries, they use gentamicin, or you can also give IV augmentin. Oral antibiotics, cefixime, 8 to 10 milligram in 2 to 3 divided doses. Augmentin, ciprofloxacin, ofloxacin, or cefalexin, or the other antibiotics that you can give it. Repeat urine cultures, whether we need to repeat the urine cultures after an infection or not. There have been studies done previously, and all the studies have shown that it's not necessary to repeat a urine culture to just document sterilization of urine. If a child had responded to your treatment and the child is recovered, there is no need to repeat a urine culture. So there is little, all these studies have shown that there is little utility in repeating the urine culture in children with UTI who are treated with an antibiotic which is susceptible to the uropathogen. So look at the clinical response and pathogen, and if the patient is not responding in 48 hours, then repeat the urine culture. But don't, if a patient is responding and you have finished the course of antibiotic, there is no need to repeat a urine culture. So how long you need to treat the children? 10 to 14 days in infants and smaller age group, or children with complicated UTI. For children with uncomplicated UTI, 7 to 10 days should be enough. Teenagers who are having typical lower UTI or cystitis features, they can have a shorter course of antibiotics for 3 days. So children who have a UTI less than 1 year, they have been treated with UTI, so they should be started on prophylactic antibiotic until you have ruled out other causes of UTI like VUR. So until you do appropriate imaging, they should be on prophylaxis. So prophylactic antibiotics, what does internationally guidelines say? The American Academy of Pediatric guidelines, which were published in 2011, again they have reviewed it in 2016. They does not recommend prophylactic antibiotics following a first febrile UTI between 2 months to 24 months. So less than 2 months you need to give prophylactic antibiotics, but between 2 months and 24 months with the first simple UTI, you don't need to give antibiotics. Again, in UK, the NICE guidelines also state that antibiotics are not routinely recommended after a first UTI, but with children with recurrent UTI, they might consider prophylactic antibiotics. In India, because of various dynamic features and lack of clinical facilities, the Indian Nephrology Guidelines does recommend prophylactic antibiotics. Ultrasound. American Academy of Pediatrics recommends renal bladder ultrasound for all infants and children between 2 to 24 months. NICE in UK recommends ultrasound for infants younger than 6 months and children older than 6 months who have an atypical UTI or recurrent UTI. Our Indian Society of Pediatric Nephrology recommends renal ultrasound to all children with first UTI. So ultrasound should be done soon after diagnosis is the recommendation from our Indian nephrology team. MCUG, it's mainly used to rule out a VUR. So American Academy of Pediatrics recommends to postpone until the child has a second febrile UTI between 2 to 24 months. And NICE recommends MCU only for atypical or recurrent UTIs in less than 6 months. In India, it's recommended that all children less than 1 year, they should get an MCU, and it's ideally done 2 to 3 weeks after the first UTI. So in this MCU, what you do is that you put a catheter and you inject a dye, and you see you take serial X-rays to see while the child is passing urine, and you want to make sure that there's no reflex. So this is a tabular form that I have taken from Indian Nephrology Society. So after a first UTI, less than 1 year, all children should have an ultrasound, MCUG, and DMSA scan. Between 1 and 5 years, they should have an ultrasound and a DMSA scan, and they should do an MCUG if ultrasound or DMSA scan is abnormal. And more than 5 years old, ultrasound should be enough. And if ultrasound is abnormal, they should go for MCUG and DMSA scan. What does DMSA scan involve? DMSA scan is basically you insert an intravenous catheter, and then you insert a dye, and you see for any scarring, and you see for kidney function. So it detects acute pyelonephritis and also scarring in acute and chronic settings. AP and NICE does not recommend DMSA after first UTI. NICE recommends 4 to 6 months after acute infection in children less than 3 years with atypical UTI and more than 3-year-old for recurrent UTI. The Indian Pediatric Nephrology, it recommends scan to be done 2 to 3 months after the treatment. So this is a DMSA scan that was done. So the left side, as you can see that the kidney uptake is only half of the right side. So the right kidney is 61%, whereas the left kidney anteriorly and posteriorly, you can see it is half compared to the right kidney. How do you prevent UTI? So you advise the families to make sure that the child takes adequate fluid intake and also frequent voiding. So especially children who go to school, they tend to hold on to urine sample, and because of they might not want to use the toilets or they are scared. So they tend to hold on, and that again causes them to be at risk of UTI. So tell them that when if you have a sensation to go to the toilet, that you need to do a frequent voiding. Avoid constipation by having high fiber diet. Double voiding. Double voiding means is that like the child goes to the toilet, passes the urine, stands up, and then again sits on the toilet and does the urine again. So this double voiding helps to empty the bladder completely, and that again reduces the risk of lower UTIs. And if in boys who have a recurrent UTI, especially children who are suffering with high-grade vesicoureteric reflex, circumcision is indicated. But while you are doing circumcision, make sure that the child has no hypospadias, because hypospadias can they need to use the foreskin to do the circumcision repair. So children with with recurrent UTIs with the VUR, circumcision is advised. So what is bladder ball dysfunction? As I said before, it is characterized by abnormal patterns of micturition in presence of intact neuronal pathways without congenital or anatomic abnormalities. So here there is a problem in filling phase. So they will have some of the children will have overactive bladder. So their bladder will be sensitive to smaller volumes. So they will be having problems with incontinence. They also have problem with evacuation phase, and children with recurrent UTI usually have dysfunctional voiding. So the features which are suggestive of bowel bladder dysfunction are they will have recurrent UTI, persistent high-grade VUR, constipation and impacted stools. As I've said, like voiding less than 3 or more than 8 times a day, thickened bladder, and residual volume of more than 20 ml. So antibiotic prophylaxis. American Academy does not recommend antibiotic prophylaxis after first UTI. Between 2 to 24 months. NICE recommends no antibiotic prophylaxis after first UTI, but might need it in recurrent UTI. Our Indian Academy of Pediatric Nephrology recommends prophylaxis with children with UTI below 1 year of age, or children with BUR, or children with frequent febrile UTIs. So there is no role of antibiotic prophylaxis in patients who have urinary tract obstructions like posterior urethral valves or urolithiasis, neurogenic bladder, or patients who are doing clean intermittent catheterization. Children with myelomeningocele or meningocele who have problems with bladder control, they do intermittent clean catheterizations at home. So these children don't need any antibiotic prophylaxis. So asymptomatic bacteria, what is it? It's the presence of bacteria and absence of any symptoms of UTI. It occurs 1 to 2% in girls and 0.2% in boys. It's a benign condition. So no treatment is required. Most common organism is E. coli. Sometimes judicious treatment of antibiotics to eradicate this asymptomatic bacteria will itself lead to causing a severe asymptomatic infection with more virulent strains. So therapy of asymptomatic bacteria or antibiotic prophylaxis is not required. Vesicoureteric reflex, so 40 to 50% of infants and 30 to 50% of children are affected. It's basically instead of urine flowing from kidneys to the bladder, it goes in an opposite direction. So there are classified into 5 grades. Grade 1 is where it only fills up to the ureter without any dilation. Grade 2 is that it fills the ureter and collecting system without any dilatation. Grade 3 is it fills and mildly dilates the ureter and collecting system with mild blunting of calyces. Grade 4 is where a reflex fills ureter and collecting system with blunting of calyces. Some tortuosity of the ureters is also present, and grade 5 is massive reflex with dilatation of calyces, and all the calyces are blunted, and there is loss of papillary impression, and intrarenal reflex may be present. So, moderate to severe VUR is a risk factor for pyelonephritis and renal scarring. So renal scarring is highest in the first year of life. Um, so in patients with dilating reflex, the outcomes from surgical repair versus prophylaxis uh, were similar in terms of number of breakthrough UTI and risk of renal scarring. So management of VUR, you don't need to do a surgical treatment. It depends upon the age, grade of the reflex, and any breakthrough infection. So you need to take seriously if the children is having VUR in less than 1 year old. Older than 1 year, you can just monitor them and observe them, and make sure that they are not suffering with UTIs. So management of VUR, grade 1 and grade 2. So up to 1 year of age, you need to start them on antibiotic prophylaxis. So after you have stopped the prophylaxis, and if child has started to have a UTI, you need to restart antibiotic prophylaxis for breakthrough UTIs. For grade 3 and grade 5 VUR, you need to give antibiotic prophylaxis up to 5 years of age, and surgery is indicated if there is breakthrough febrile UTI. Beyond 5 years, prophylaxis is continued if there is bladder bowel dysfunction. So management for VUR. So children with VUR will need repeat imaging after 18 to 36 months, mainly with children with grade 3 to grade 5 reflex. So prophylaxis can be discontinued in children older than 5 years. If they don't have any bladder bowel dysfunction, you can stop prophylaxis even if they have grade 1 to 2 reflex. So reflex is inherited in an autosomal dominant. So 1:2, like there is a 50% chance of them inheriting. So 27% of siblings and 35% of offspring of patients show VUR. So any child who there is a strong family history of VUR, you can recommend ultrasonography to rule out presence of reflex. So follow-up. Patients with renal scarring are counseled regarding the need for early diagnosis and therapy of UTI and regular follow-up. So they need to be monitored every 6 to 12 months in outpatient basis, mainly to check for physical growth and blood pressure. And annual ultrasounds are done to monitor the renal growth and also to look for any hydronephrosis. So what are the indications for referring to a pediatric nephrologist? Most of them you can manage them in a pediatric clinic or in a pediatric setup. There are few indications, however, that they need to be referred to a nephrologist. These are recurrent UTIs, UTIs with bladder bowel dysfunction, patients with VUR, and any child who has an underlying urological or renal abnormalities, they need to be under a pediatric urologist, and children with renal scar, deranged renal functions, and hypertension.